Welcome to our session on shigellosis, the classic cause of bacillary dysentery. Shigella is highly contagious, requiring only a few hundred bacteria to cause infection. This makes it a major public health concern, especially in areas with poor sanitation. Let's begin with a typical case. A 16-year-old boy returns home after a 2-week stay at a camp in a rural area. The very next day after returning, he experiences acute onset of fever, crampy abdominal pain, and watery diarrhea. Notice the timeline carefully. By the next day, so now day 2 of illness, he develops tenesmus. Tenesmus is that painful, urgent feeling of needing to pass stool, even when the bowel is empty. This is a hallmark of colonic inflammation and should immediately make you think of invasive diarrhea. He also notices mucus and a bloody tinge in his stool. The stools then become grossly bloody and increase in number. This progression from watery to bloody is classic for Shigella infection. Understandably worried, his mother takes him to the emergency department. In his exposure history, the patient had drunk water on several occasions from a well during his camp stay, but had no contact with other sick persons. This contaminated water source is likely how he acquired the infection. This case demonstrates the typical presentation of shigellosis: acute onset, rapid progression from watery to bloody diarrhea, tenesmus, and a clear exposure to potentially contaminated water. Let's understand Shigella from a microbiological perspective. Shigella are gram-negative bacilli that are non-motile and facultative anaerobes. The non-motile characteristic helps distinguish them from other enteric pathogens, like Salmonella, which are motile. Shigella is the causative agent of bacillary dysentery, bacillary meaning bacterial, as opposed to amoebic dysentery caused by Entamoeba histolytica. There are 4 species of Shigella, divided into serogroups A through D based on differences in their O antigen. S. dysenteriae is serogroup A with 12 serotypes. This is the most common and most pathogenic species, responsible for epidemic dysentery. S. flexneri is serogroup B with 6 serotypes. This is also quite common in developing countries. S. boydii is serogroup C with 18 serotypes. This is less common globally. S. suni is serogroup D with a single serotype. It's the least pathogenic, but is actually the most common species in developed countries like the United States, where it causes milder disease. Shigella has remarkable invasive properties, penetrating the colonic mucosa to cause local necrotic lesions. This is why we see bloody diarrhea. Critically, humans are the sole source of infection. There's no animal reservoir. Transmission follows the quote, 4 F's rule: fingers, flies, food and feces. Person-to-person spread is particularly important. What makes Shigella so pathogenic? 2 main virulence factors. First, invasive capacity. Shigella uses invasins and outer membrane proteins to invade intestinal epithelial cells. These molecular tools allow the bacteria to penetrate cells and spread from cell to cell without entering the bloodstream. Second, production of cytotoxin, specifically shigatoxin. This potent toxin is encoded by S. dysenteriae serotype 1 and is responsible for the severe tissue damage and systemic complications we see in shigellosis. Remember, the combination of invasion plus toxin production makes Shigella particularly dangerous. The invasion causes the inflammatory response and bloody diarrhea, while the toxin causes cell death and can lead to complications like hemolytic uremic syndrome in severe cases. Now let's understand how it causes dysentery. Entry occurs through the oral route, and here's what makes Shigella unique. Only a few hundred bacteria are sufficient to cause infection. This is an incredibly low infectious dose compared to most other pathogens. For comparison, Salmonella typically requires thousands to millions of bacteria. This low infectious dose explains why Shigella spreads so easily in communities, and why person-to-person transmission is so efficient. After surviving gastric acid, bacteria reach the terminal ileum and colon. Notice it primarily affects the large intestine. Shigella is taken up by M cells in the intestinal mucosa, similar to what we saw with other invasive pathogens. However, once inside, Shigella does something clever. It multiplies within enterocytes and spreads laterally to adjacent cells without leaving the epithelium. Think of it as moving from house to house, without going outside. The cytotoxin, particularly shigatoxin produced by S. dysenteriae, inhibits protein synthesis, resulting in cell death and tissue necrosis. The result is dysentery, that's diarrhea with blood, mucus, and painful abdominal cramps. Notice there's no substantial fluid loss, like we saw with ETEC. This is inflammatory diarrhea, not secretory diarrhea. Dysentery typically lasts longer than watery diarrhea. It can persist for several days. However, most cases resolve spontaneously in 2 to 7 days in healthy individuals, though severe cases require antibiotic treatment. The specimen of choice is stool, especially the portion containing mucus. Why mucus? Because that's where the bacteria are concentrated. The appearance of stool changes with disease progression. In early stages, stool is watery with little blood and mucus. In late stages, it's almost entirely pus and blood mixed with mucus. This is classic dysenteric stool. For microscopy of feces, you'll see abundant red blood cells and many pus cells. This confirms inflammatory diarrhea and helps distinguish it from non-inflammatory causes. For culture, we must use selective media because normal stool flora would overgrow Shigella. The selective media used are XLD agar, xylose lysine, deoxycholate agar DCA, deoxycholate citrate agar, SS agar, Salmonella Shigella agar. Shigella is a non-lactose fermenter, so it produces colorless colonies on these media, making it easy to identify presumptively. For identification, we perform biochemical tests to confirm it's Shigella. Then we do slide agglutination tests using specific anti-sera to identify the O antigens for serotyping. This tells us which species and serotype we're dealing with. A bacterial agglutination test can also be performed using high-titer serum containing antibodies against the isolate. Finally, and this is crucial in the era of antibiotic resistance, we must perform antibiotic susceptibility testing. Resistance is increasingly common, so empirical treatment may need adjustment based on susceptibility results. For treatment of shigellosis, the primary antibiotics are ciprofloxacin and azithromycin. Ciprofloxacin is a fluoroquinolone that's highly effective, though resistance is emerging in some regions. Azithromycin is increasingly used, especially in children and areas with fluoroquinolone resistance.